Hello, let's talk about this SDL titled Ischemic Bowel Disease. I'd like to scan through the document once and just kind of point out where the questions are going to come from in this one because there's a lot of little tiny details in this text. It's conceptual, lots of physiology, and I don't want to get sidetracked. I want to focus on what's important first. So, mesenteric ischemia is essentially small bowel ischemia because half of your colon doesn't really have a mesentery. It's retroperitoneal, your ascending and descending colon. So when we say mesenteric ischemia, we're talking about the small bowel. And you've got four big causes of small bowel ischemia. Ischemia essentially being hypoperfusion or not enough blood flow to tissues, and then they start to die off as a result. One thing that can cause that is an embolism in a large or medium-sized artery. Another thing that can cause that is a thrombosis, which is a clot that develops on the wall of an artery, and this is heavily associated with atherosclerosis and the rupture of the fatty plaque. The third type of way that you could get small bowel ischemia is through non-occlusive mesenteric ischemia, or NOMI. And this is essentially a spasmic vasoconstriction of the very small capillary beds and small arterioles of the gut. This would be analogous to if we're thinking about the Hart-Prinz-Metal angina, which is a vasoconstrictive angina, right? And then finally, we've got our venous thrombosis that can lead to a mesenteric ischemia. Makes total sense, right? What's a venous thrombosis? A clot in a vein. So if you plug up a vein, hydrostatic pressure builds up and backflows back to the capillary bed, back to the arteries, and you've got edema everywhere, and you've got ischemia of the tissue because of poor blood flow forward. So those are our four main causes of gut ischemia. And then we talked for a little bit about ischemic colitis in this SDL. And ischemic colitis is ischemia of the large bowel, which is not as common as small bowel ischemia, probably 4 cases, 5 cases of small gut ischemia for every 1 case of ischemic colitis. And the big difference between ischemic colitis and small bowel ischemia is that ischemic colitis is typically pretty localized. The patient's able to point to some left upper or left lower quadrant pain, and it's because there are these 2 watershed areas of the colonic blood supply that preferentially go ischemic first anytime blood flow to the transverse descending sigmoid colon is obstructed. And so I think that that's the real big question that could come out of all the talk in this SDL about ischemic colitis is what's the reason why you've got colitis at the splenic flexure or down at the rectosigmoid junction, right? And it's going to be because of one of these 2 named watershed areas. So then the SDL talks about the pathology of it all, and it's basically the same thing that we've seen with infarctions of the heart. First, your mucosal layer goes, and then it spreads transmurally, meaning that blood vessels penetrate the wall of the gut, just like how they penetrate the heart. You've seen all this before. And then the innermost layer is going to die off first. And that's what it looks like grossly. So a transmural infarction involves the muscularis propria. A mural or mucosal infarction does not. I think if they pull any sort of physiology type question out of that, it's going to be related to this transmural infarction involving all 3 layers of the gut. Here's the 2 weak points in the large bowel again. That's probably going to be a question on a clin med, cell bio, some sort of test, if not this one, anatomy. And then we talk about the clinical presentation of the, remember we said 4 big pathways or events that could lead to ischemia of the small bowel. And we said you could get a embolus, which is a moving clot in the bloodstream, or you could get a thrombus, which is just a clot that is staying in place. It hasn't gone anywhere yet. And so both of those present pretty similarly and may lead to some peritoneal signs, leading us to suspect an acute abdomen. And so, again, this section is just talking about the diagnosis and the separation in your mind of these different causes of mesenteric ischemia. Non-occlusive is typically associated with patients who are already in the ICU. That's that NOMI acronym. And mesenteric venous occlusion, well, what's that going to present as? Slow and following some sort of hypercoagulable state. Maybe patient was on a flight or a long car drive or had cancer or is on contraceptives, oral contraceptives. So that section's just talking about the presentations to help you tell them apart. Intestinal obstruction is what we get into next. And so the big question is, how is this patient obstructed? Why are they obstructed? And you'll get some little clues. And the most common means of them being obstructed are going to be adhesions, which typically follow surgery. It's essentially scar tissue in between different pieces of the GI tract, maybe a communication connection to the internal wall of the abdominal cavity. Tumors can also give you an obstruction, and so this may be used as a lead-in to a question about perhaps an annular colorectal carcinoma in the descending colon, let's say. Incarcerated hernias might be asked of you. They're talked about for about a page total in length in this SDL. We mentioned them here. We mentioned that there's a difference between incarceration and strangulation. So you might get asked to say, well, what's going on? They ask you and they give you 5 different things and maybe volvulus and intussusception or 2 throwaway answers. But what they really want to know is, do you know if this hernia is incarcerated or strangulated, which is one step worse than incarcerated. Crohn's disease, you could see a lead into a question about that. We've got a whole SDL upcoming about CD and ulcerative colitis. Then finally, intussusception and volvulus, you need to be able to recognize these grossly if you get shown an autopsy report or an open abdominal cavity and it just points with an arrow to what's going on in the gut. Be able to recognize and differentiate the two of these. And that's about it in terms of what you could get asked as far as I know of. This final section talks about ileus, which is basically atonic gut. It's not an obstruction, it's just the gut won't move. And typically we refer to post-operative ileus because after you wake up from abdominal surgery, like laparoscopy perhaps, your gut just doesn't want to squeeze, it doesn't want to move. And this can be due to a host of things, but what's really testable is a couple of different drugs that we have already seen that can cause an ileus, which is going to be, again, the bowel is frozen, it's a frozen bowel, and opioids can cause that. And so this can be a presentation of opioid abuse, remember, constipation, and then anticholinergics as well. Remember that M3 receptor is localized to the gut, and any binding of acetylcholine to M3 is what induces peristalsis, and that's the name of the game throughout the whole GI tract from the mouth to the other end. So that's my 2 cents in terms of what you could get asked. Again, big focus on the 4 different types of ischemic bowel disease because all 4 of them have different risk factors and all 4 of them have different predisposing conditions. So that's going to be the question. They're going to ask you something like, they'll say, oh, the patient's got a blockage in this medium artery, right? Maybe the patient's got an obstructed right colic artery, and you're going to have to say, oh, that can't be a thrombosis. That affects large arteries. That can't be NOMI. That affects the arcades and the vasorectum. That has to be an embolus. And so how does the patient get a thromboembolus all the way down to the right colic artery? Well, it probably came from the heart, and the patient probably had an MI or they had atrial fibrillation, something like that, that broke a clot off from the left atrium. Typically, the appendage, remember, is where clots like to form because of stasis of blood flow, and it kicked that clot all the way down the aorta, and it went into the superior mesenteric and ended up occluding the right colic. And so that's the question, basically. And if you can think about these different causes of bowel ischemia frontward or forwards and backwards all the way through their development, just like that, then you've got this. The 5 questions from this SDL should be a piece of cake. So that's the levels of analysis that we're looking at. Where is the occlusion that's leading to ischemia? What caused the occlusion? What are the risk factors for what caused the occlusion? And if you can think through that, again, that's 2 or 3 questions right there. So now I'll talk about the whole SDL as I normally do, because I do like this SDL. So ischemic bowel disease, again, ischemia of the gut. When we think ischemia, what are we thinking? We're thinking hypoperfusion. That's basically synonymous for our purposes with ischemia. And so the lack or compromisation of blood flow to a region of the gut means that your cells are going to run out of oxygen, and they need oxygen to be the terminal electron acceptor to their electron transport chain so that they can keep spinning that kind of wheel-like, hub-like ATPase and cranking out adenosine triphosphate, which any cell uses to power all of its metabolic machinery, but also all of the ion pumps that allow it to maintain tonicity in the face of a constantly changing environment. So you run out of ATP and the cell dies. So ischemia means you're running out of ATP, and it's typically acute or chronic, arising from occlusive or non-occlusive etiologies. And the reason why we care so much about this, well, there are a couple of reasons. Number one, acute mesenteric ischemia, if you can't correct the underlying cause, or if the patient's just the rest of their systems are too far gone, they're probably not going to make it. This is a severe disease that can go very downhill very quickly. Something complicating that is the fact that your gut is the interface between your body and the outside world. And as a result, there's a lot of pathogens throughout your small and large intestine, and there's a lot of toxins too in the different things that you eat. The reason that you poop is because some of what you eat you just can't absorb. Your body can't do anything with it. So if you have ischemia or necrosis of the bowel wall, well, then all of the things inside the lumen of your gut that are toxic and all of the pathogens that are normally sequestered within that lumen are going to have access to your bloodstream, and that can lead to some sepsis very quickly. So the pathophys of ischemia is discussed. And ischemia to the bowel, generally, we're thinking something's wrong with the heart, something's causing it to not deliver enough blood to the gut, maybe something's wrong with the vessels, the vasculature supplying the gut. That would be an example of atherosclerosis. Maybe the patient has a bleed elsewhere and they're going into shock from that. Maybe there's a respiratory problem causing hypoxemia, and so you've got fluid flow, but it's not oxygenated blood. That could cause an ischemia of the gut. And when we're thinking about the gut particularly, there's a couple of peculiar things about the GI vasculature that it helps to bring up front to aid your understanding for the remainder of this talk. First of all, your gut doesn't have a constant blood flow. Anytime you need to get up and go, your brain just squeezes and shuts off all of the flow to your gut, most of it at least. And so anything that's going to get you sympathetically ramped up is going to way decrease the perfusion of your small and large intestines. And secondarily, because your gut is kind of used to this shutting off the flow and then starting it back up again, it is very capable of growing collaterals between different arterial beds in the event of a clot or a atherosclerotic occlusion, because there's a lot of arteries down there. They're close together. It's easy for them to branch over in anastomose. And again, because you're constantly turning that blood flow to your bowel off and on, it's kind of used to ischemia to begin with. So it is pretty resistant to ischemia. And then the neurogenic and local control, I think that we just talked about that pretty well. But for a bit more resolution into that discussion, remember that norepinephrine, epinephrine is going to bind to alpha-1 receptors on blood vessels and cause vasoconstriction. And so anything that puts norepinephrine and epinephrine in your bloodstream is going to constrict the gut. Still talking about general principles of ischemic bowel disease. Transmural ischemia, the whole wall is ischemic, can lead to gangrene, which is, this SDL defines it well. Gangrene is necrosis plus infection. You've got a necrosis and then there's bugs superimposed on top of that dead tissue. However, if it's not a transmural ischemia in the gut, quite like in the heart, you're not going to see a big degree of necrosis. You're just going to see some dead tissue, but you'll have a lot of living tissue left. And so the dead tissue will get cleared out and scarred up, and there's no necrosis, there's no gangrene. Now, the earliest form of ischemia produces changes at the tips of the villi and the enterocytes. That's the first cell down. And again, that's because blood vessels penetrate into the wall of the gut from the outside in. And so if you were to squeeze one of those blood vessels, the very first place it's going to get ischemic is the most peripheral tissue supplied by that blood vessel in the gut. That's the enterocytes of the mucosal layer. So let's say you do get ischemia. What happens next within your gut? Well, first you go a little spasmodic, and this is when symptoms of vomiting and diarrhea present. But as the ischemia progresses, eventually you're just going to lose that tissue, and so you're going to be unable to squeeze, conduct peristalsis on that dead tissue, and you're eventually going to get a slowed GI transit. And as that ischemia persists, it obviously irritates nearby tissue, creating inflammation and an immune response, leading quickly to peritonitis. Because anytime you have a necrosis, especially a full thickness of a necrosis, you might as well consider that a perforation, because that tissue is not stable whatsoever. We talk a bit about vasospasm. We'll touch that later. And finally, reperfusion injury. Reperfusion can be a mechanism of acute bowel ischemia because anytime you withhold blood from a tissue and then let it all back in at once, well, what's inside that blood that's really important for those cells? Oxygen. So if you have a lot of oxygen all at once, well, your cells are going to be running their electron transport chains as fast as they can, but they're not going to be able to run them fast enough to process all of the local oxygen gas in the area. And so the oxygen can form free radicals. I mean, that's what ROS stands for, reactive oxygen species. And so that's what leads to reperfusion injury. And that's got a very big risk for sepsis. And sepsis is going to go downstream into disseminated intravascular coagulation and MODS, multiple organ dysfunction. So now we have reached the good part of the SDL where we start breaking down the four, again, there are four of them, big causes of acute mesenteric ischemia. Number one is an embolism. As we said, the embolus typically comes from the heart. It's typically a blood clot that formed in the left atrial appendage. This is the predominant cause of mesenteric ischemia. The superior mesenteric artery is most commonly affected, and that's because if you've got your aorta popping down, your celiac trunk is kind of like a 90-degree angle off it, but your mesenteric is more like a 45 or even like a 30-degree angle. It's a very, very it's easy for a clot to go down into an angle that is that narrow. I guess it would be narrow, maybe steep. I don't know. All depends on what side of the street you're standing on, is what I'm trying to say. So superior mesenteric artery. And embolic occlusion most often occurs distal to the origin of the superior mesenteric, because the embolus gets pushed down into the artery by blood flow as far as it can go. So this diagram in the middle of page 4 here illustrates all the different etiologies very well. And I've circled where you would see an embolus in blue. And the big concept is that you're seeing an obstruction of some of the vascular beds off stream of the SMA, but not quite all of them. And that's going to help you differentiate between the embolus and a thrombus. Arterial thrombosis typically happens due to atherosclerosis, and it likes to pop up right at the entryway to these large arteries branching off the aorta. So the celiac, the SMA, the IMA, they can all get atherosclerosis. So they're all potential sites of arterial thrombosis. And remember that the way that you get a blood clot from atherosclerosis is that you've got this fatty plaque that's building up, but eventually this fatty plaque is going to acquire a cap to it, right? And it's going to have a fibrous cap to it. And there's fibrin also like laid throughout the plaque, just holding it all together. So if this plaque gets injured, let's say the top gets knocked off of it, well, then you've got a lot of exposed fibrin. And you've also got a lot of endothelial damage in the area, and that's going to encourage platelet aggregation on the base of that atherosclerotic plaque that has ruptured or broken somehow. So that's your thrombus. Typically, again, occurs at the origin of these medium named arteries. I can see them asking about risk factors for atherosclerosis. Remember, number one risk factor for atherosclerosis is age. You can't escape it. It happens to everybody eventually. And hyperlipidemia is our number one modifiable risk factor that you can actually do something about. So know this picture and probably know the labels that I've put on it, because that's really what the picture is trying to illustrate, although not very overtly. Non-occlusive mesenteric ischemia, really cool. There's no clots involved. There's no emboli involved. But you do see ischemia due to reduction of arterial blood flow. So it's on the artery side of the capillary bed, and it's due to vasoconstriction. And if you did some MRA on this patient, some angiography, what you would see is all the large vessels are going to be totally patent, but then you're going to get about a centimeter, couple centimeters away from the blood vessel where it's supposed to be meeting the bowel wall, and then the contrast dye is just going to stop. It's going to go away, and it's because your arcades and vasorecta down entering the GI tract, the wall of that gut, are so squeezed shut that no blood's going to be able to get through them. So NOMI is a complication of severe systemic illness. These patients are typically already in the hospital, and they have a comorbidity, and they've been there for a few days or so. Sepsis, MI, heart failure, bad pulmonary stuff, all of that can contribute to NOMI. So then the SDL brings up a cool point. It says patients with these systemic illnesses are often receiving multiple drugs known to reduce intestinal perfusion for inotropic support. And remember, inotropy is basically contractility of the heart. And so whenever your patient's going into, let's say they're going into septic shock, what sort of drug would you give them? I hope you would be thinking of something like phenylephrine, or maybe norepinephrine, something with a very strong alpha-1 activity to constrict those blood vessels. Because in the setting of especially a septic shock, what's going on is that you've got all of these cytokines like interferon gamma and maybe an IL-1 and some TNF-alpha and some endotoxins off of gram-negative bacteria too, right? You've got all these things in the bloodstream traveling systemically throughout the whole body. And what do those molecules all have in common? They stimulate vasodilation because they activate the immune response. And the first step in the inflammatory immune response is vasodilation. So you can get neutrophils and macrophages and lymphocytes into the area. So to combat this vasodilation, which is leading to the shock, we pump the patient full of a lot of vasoconstrictor, essentially. And so remember that your sympathomimetics are the drugs that do that. And that, again, your body does the same thing. Your sympathetic nervous system will constrict arterial supply to the gut in order to supply your brain better, say when you're exercising. And so that's why they're called sympathomimetics. They do the same thing that the sympathetic nervous system does. So recognize, although the SDL doesn't say it, that's a bunch of drugs right there, like isoproterenol, you know, like dobutamine, Those are drugs you could see on a test that would lead to non-occlusive mesenteric ischemia. And then the SDL does mention a couple more. Digitalis, what drug is that? Digoxin, when do we give that? Heart failure. Cocaine, when do we give that? Psych. Diuretics and vasopressin, vasopressor agonists, receptor agonists, can also cause regional vasoconstriction. So I feel like that's got my radar going off, that's for sure, in terms of test questions. So then we talk about mesenteric venous thrombosis. It is what it sounds like, venous thrombosis. How do you get it? You're hypercoagulable. You got polycythemia vera. That means you got a lot of red blood cells. Protein CNS deficiencies. What drug could give you that? Warfarin. I'm sorry. Warfarin's not going to make you hypercoagulable, though. Redact that. Portal hypertension. Okay, yeah, I dig it, because you're going to see stasis in venous beds and capillary beds if you've got portal hypertension. Where else is the blood going to go? Blunt abdominal trauma. Again, a lot of fluid edema, and clotting cascade is going to be activated because of all the cell damage going around there. Malignancy, yeah, cancer can give you a hypercoagulable state. And oral contraceptives. So a lot of risk factors that you would probably expect to be involved in the development of a venous clot. And that's the most likely angle of testing that single pathology is what caused it. Chronic mesenteric ischemia. Mesenteric or small bowel ischemia does not tend to be chronic. If it's chronic, it is absolutely related to atherosclerosis, and something that might help you pick it out. Relative ischemia occurs after meals when there is an increased demand for flow into the mesenteric bed. Vasodilation after eating ought to fully perfuse the gut, but due to atherosclerosis, the gut doesn't get fully perfused, and so you get some symptoms. That's chronic mesenteric ischemia. Again, what's it caused by? Atherosclerosis. What's the question going to be about? Probably atherosclerosis. Ischemic colitis. So this is ischemia of the large bowel, not the small bowel. And a couple things they could ask you about this. Number one, like, what are the implications of a lack of large bowel functions? And so your large bowel absorbs a whole ton of ions and fluids from the bloodstream. And then your large bowel also has a lot of bacteria which produce vitamin K. And so if you have to resect a portion of the large bowel, two things are going to happen. Number one, the patient's going to have a whole lot of diarrhea for the rest of their life. Number two, the patient might go into a vitamin K shortage, and as a result, they would be hyper or hypocoagulable. Well, vitamin K gets gamma carboxylated, and then it goes on to activate clotting factors. And so if you didn't have enough, you wouldn't have enough clotting factors, so you would be hypocoagulable. You wouldn't clot. There you go. Then what they could also ask you about ischemic colitis is, well, what artery got occluded? You know, like what artery got knocked off? And the marginal artery of Drummond is one that some people don't have. This is a collateral artery that when it's there, it gives you collateral circulation in a watershed area. But if you don't have one of these, you are more prone to ischemia in the splenic flexure of the colon. There it is in the text. In about 10% of patients, the marginal artery of Drummond is small and devoid of vasa recta for a length of 1 to 3 centimeters. Then you have a similar area down at the junction of the rectum with the sigmoid colon called Sudex point. In a percentage of patients, the anastomosis between which two arteries? The sigmoid artery and the superior rectal artery. So that's the possible question from that. Section titled Pathology. Kind of covered it quickly at the start. Again, recognize this transmural infarct is involving all three layers, but recognize the muscularis mucosa. I'm sorry, the muscularis propria, your proper muscular layer. Well, that's not fully penetrated in either of these other two types of infarcts. And it's typically a pretty sharp demarcation between ischemic and healthy tissue. As we see here, ischemic tissue on the left, normal tissue on the right. And if you were to look through a microscope, you would see a lot of fluid edema. So all of these white cracks, they look like cracks in the tissue. That's fluid edema because fluid's investing within the layers of this gut wall and causing expansion in between sheets of cells, essentially. So that's how to spot edema on histology. The bowel wall is going to thicken because of this edema. That's an important point. Why do you get a thick bowel wall in bowel necrosis? Well, because so much fluid gets into the wall of the bowel that it literally expands. It separates. Bowel also becomes flaccid, no ATP, smooth muscles not maintaining tone, because muscle is a soft tissue, you know, it's not like a bone. You can't just like stick it there and it'll keep its shape. No, it has to use energy to maintain its tone. So if it doesn't have ATP, it just flops. Histologically, we're seeing edema, hemorrhage, a lot of spare red blood cells, surface necrosis, because again, that epithelial layer, the enterocyte layer is the first layer to go. And with all these cracks in the epithelium, I mean, this is an object lesson right here. With all of this damage, especially to the mucosal layer, you see how easy it is for bacteria to just worm their way into a venule, arterial, capillary bed. You know, they can get right into the bloodstream this way. And even if they don't get into the bloodstream, again, with all of this edema, do you see how, like, this tissue is not going to last very long at all inside the body before it just crumbles up. And we call that friable. And we would call a tumor friable, for example, or any tissue really, if you touched it and it just started bleeding. And what that represents is that it's not very tightly held together. And what that means is it's really not protected at all against the elements. So again, if you just touched this gut wall, it's just gonna crumble like dry plaster. And so that's the perforation. And so where's the bacteria going? Into the peritoneal cavity. So whole line of questioning could be opened up by a perforation. Let's talk about the clinical presentation a little bit more in detail. So if you got peritonitis, you're going to see peritoneal signs. And peritoneal signs include rigidity, washboard abdomen, guarding. Involuntary guarding means that, you know, like patients' eyes are closed. They don't know that you're going to touch them. And then you barely put your finger on them. And then all of a sudden, boom, you know, they're like Chuck Norris, you know, they're like Bruce Lee. They're just ready to go. And it's like, that's abdominal guarding. Rebound tenderness is put your hand on the patient, you press down, and it kind of hurts, but then you take your hand off the patient, and then, oh, it really hurts wherever they have the peritonitis. And the reason why it's going to hurt there is because, well, peritonitis is inflammation of the peritoneum, and your peritoneum has a visceral and a parietal layer, and there's lots of nerves inside of it. And so whenever you push down on this waterbed, think of it as a waterbed. You push down on, somebody sits on one side of the waterbed, what's the other side do? Boing, you know? So it's like that. So whenever person gets off the waterbed, what happens to the other side of the waterbed? Oh, it collapses and it goes down flat. And that snapback movement of the injured peritoneum is what causes rebound tenderness. So that's a peritoneal sign. And then a fourth one that I haven't really listed here is going to be just absence of bowel sounds. That's also a very, very bad sign. And so why do we care about these peritoneal signs? Well, they're indicators of severity. And particularly, you might suspect an acute abdomen, which is essentially the name that we give for any source of inflammation that has eroded through the gut and has free reign within the peritoneal abdominal cavity. And so when you suspect an acute abdomen, you got to open the patient up and look around. That's not a laparoscopic procedure, reason being that you have no clue, honestly, what's in there. You might have a good idea, but you don't really know what you're going to see. And so if you were to only CT and then do the procedure with cameras, you know, you might actually miss the cause of the acute abdomen when you could have had a chance to fix it. And ischemic bowel disease very commonly leads to acute abdomens. Because again, that bowel wall gets thick, filled with edema, then necrotic, and then perforation. There you go. So acute small bowel arterial inclusion, they kind of lump together the embolus and the thrombus in this section. Vomiting and diarrhea are going to be your first couple symptoms. Bowel's going to go spasmodic almost. But then it's going to run out of ATP and it's going to go flat. And that's when bowel sounds can transition to being absent. Patients typically going to have some diffuse abdominal tenderness, and especially as that mucosal layer of the gut really starts to die, you could start seeing hematochezia, spillage of blood into the stool. Or you'd call that dysentery if the patient had a particularly bad diarrhea. Lab studies are not helpful in diagnosing mesenteric ischemia, but you are going to be constantly monitoring a ion panel as well as kidney status, because there's always the potential of third spacing, which is going to be leakage of body fluid into the abdominal cavity as a result of all of the edema that goes alongside a backed up arterial bed or any source of ischemia. You get tissue edema, the layers of the gut wall start to separate, and then fluid goes into the peritoneal cavity along with the perforation. So you might be able to catch that on CT. We like MRA. That's a really good modality for diagnosing, especially those arterial causes. Plain radiograph of the abdomen may demonstrate gasless, fluid-filled bowel loops with dilatation and edema in the bowel wall. So that's going to be a stretch of gut with a very thick wall in it. High-resolution CT or MRAs are gold standard. Now, non-occlusive mesenteric ischemia is going to help you make the diagnosis on a test. Again, patients with NOMI are often already in an ICU setting. So these are patients who have something bad, some sort of heart failure, some sort of septic shock. Maybe they were in ARDS. Maybe they are taking a cocktail of drugs that are particularly vasoconstrictive. And that's going to lead to, again, the small arteries of their gut bed clamping down and vasoconstricting and leading to this slow onset symptomatology that can all of a sudden kind of just drop off the cliff. Vomiting is going to be involved, and patients going to later become hypotensive and tachycardic as the ischemia persists and turns into gut wall edema, which is going to turn into fluid leaking into the lumen of the bowel and into the abdominal cavity, and that's your third spacing. Finally, mesenteric venous occlusion. Subtle presentation. They're basically going to tell you, hey, we found a blood clot in this patient in a vein. So again, portal hypertension, big risk factor, hypercoagulable state. Anything that causes that can give you mesenteric venous occlusion. And that's your answer choices, A through D, essentially. And they're going to give you a patient with an acute ischemic bowel and try to get you to figure out the cause of it. So with chronic mesenteric ischemia, we said again, number one, most importantly, this is pretty much hand in hand with atherosclerosis. Number two, this occurs most prominently following a meal, because postprandially is when your gut needs a lot of blood. And so if you have bad atherosclerosis of your celiac and SMA and IMA, you don't know about it. When you know you're going for a jog, you have no clue, because it's like your gut doesn't need any blood flow. Then it was going to be clamped shut anyways. But when you need to digest some food, that is when any hindrance of flow into those beds is going to be made symptomatic. Ischemic colitis, acute onset abdominal cramping, pain, the urge to defecate, hematochezia. So nothing you haven't seen before. What really separates colitis from small gut infarction is that in ischemic colitis, the patient's going to say, oh, right there, it hurts so much right there. Reason being, because it's not right in the middle of their body. Your colon goes kind of around the sides of your abdominal cavity, right? Kind of like the sides of a rectangle. First it goes up the right side, and then it goes over the top, and then it goes down the left side. So the patient's not going to have pain all over the place like they would if their superior mesenteric was completely included. No, remember, ischemic colitis is due to watershed infarcts typically, not large artery infarcts. And so because it's a watershed infarct, it's a really localized infarction. And so they're going to point right to where the infarct is, usually in a test question. Not saying real life, I'm saying test question. Principles of treatment are fluid care and airway protection primarily, especially if patient's already in the hospital for something else. If it's a blood clot, you're going to have to cath them and get the clot out of there. You want to anticoagulate them prophylactically with heparin and warfarin, even if you're not 100% positive if it's a clot, I'm sure. If you know exactly what's causing the ischemia, you might be able to get away with a laparotomy, which is open surgery, actually. So yeah, we said before, you're going to have to basically go open surgery and open these people up most of the time, because again, you're not entirely sure. You're never really entirely sure what you're going to be seeing until you actually get in there. Survival's not good. So now we have a section on intestinal obstruction and small bowel obstruction, handful of causes. Anytime you have a mechanical gut obstruction, it's typically the small bowel. It's easier for that bowel to get twisted up in itself, and it's also got a larger surface area, so adhesions are more common. Now, adhesions develop secondary to gut surgery, and it's a fibrous scar tissue, kind of the same consistency, I believe, as like a saran wrap, like plastic wrapping. And pelvic operations, not just gut procedures, but pelvic procedures too, like a hysterectomy, good example, appendectomy. anytime you got to go into that peritoneal cavity, adhesions are a big risk, and it's not always necessarily instantaneous. It could be 20, 30 years down the line. The patient comes in complaining of they can't go to the bathroom, and you're thinking, well, are they constipated? Are they obstructed? You know, tumors can give you an obstruction. That should make a lot of sense. Just a mass protruding into the lumen of the gut. And we've got a lecture on colorectal tumors. And so, again, gateway to that sort of question. Incarcerated hernias may cause intestinal obstruction if they're not fixed. And I suppose an incarcerated hernia is by definition a hernia that can't be reduced, right? So if you could reduce it, it'd just be a simple hernia. But if you can't reduce it, it's stuck in the bowel wall. That's what we call an incarcerated hernia. Now you can take that one step farther and say, well, that part of the hernia that's stuck, that herniated gut that's stuck in the bowel wall, that could become infarcted. So it could die because it wouldn't be getting a blood supply. And if it were to do that, we would call it strangulated. So incarcerated means stuck in the gut wall, like a prisoner. So that should make sense. Strangulated means, oh, it's dead. You're not getting it back. So strangulated, that should make sense too. So if you get shown incarcerated, strangulated hernia in a question, even if they're just confounding answers, choices, now you know what they are. Crohn's disease. Talk about that next time. Strangulation, again, is the arrest of blood flow to a herniated section of bowel. Although it can also, you can also see strangulation in intussusception and volvulus. Anytime you got a part of the bowel that's pinched down on two sides, not just one side, but two sides, well then the part of the bowel that's ischemic in between the two different spots that have been pinched, that's going to be your strangulated portion of bowel. So it's really easy to get gangrene down there, which is, again, necrosis with infection on top of it. There's a lot of microbes in the gut. And you want to be able to recognize intussusception and volvulus. I'm going to explain those. They're actually very self-explanatory. So what's going on during an obstruction? First, you see an increase in peristalsis because your gut's going to back up with contents, and you know, stretch receptors trigger peristalsis. The more you dilate the bowel by putting stuff into it, by pushing poop into it, essentially, the more you're going to get that bowel to contract to attempt to clear it out. But the problem is you've got an obstruction. But that stretch-mediated feedback contraction, that's why you get the peristalsis. But again, the bowel's going to use up all its energy, all its ATP trying to do that, and then it's just going to stop peristalsis. As the bowel dilates, fluid edema pools. As there's a buildup of hydrostatic pressure, be it an obstruction of blood flow somewhere, like a direct obstruction of blood flow, so a clot is going to give you edema proximally to the clot. But even downstream from the clot, as tissue dies, it's going to start to just let off water. So fluid likes to go from the body into the lumen of the gut. And that's the reason why hemodynamic control is our top priority in any patient with an ischemic bowel disease or an obstruction. That's something we're constantly monitoring. Changes in flora. So normally the small intestine has no bacteria in it, but you compromise its blood flow and you can see what's called small intestinal bacterial overgrowth. And a handful of species really like to do that. E. coli, Streptococcus faecalis, which is Enterococcus in the sketches, and Klebsiella. E. coli, Klebsiella, those are gram negatives. Lactose fermenters. Symptoms of intestinal obstruction include colicky abdominal pain. And I didn't know what that word colicky meant, but it's essentially the same thing as crampy abdominal pain. And the reason why you would get a colicky abdominal pain is related to the peristalsis that's mediated by the stretching out of the gut wall anytime you have an obstruction causing a backflow of stool. So the way that things go is you get a lot of poop, and then your gut says, oh, I need to clear this out of here, so it contracts, but it's pushing against a brick wall. So that causes pain. And that's where you get this colicky pain from. But the thing is, it's not constant pain, because your gut's not that dumb. It's like, well, okay, we couldn't get it to go anywhere this time. Let's wait a little bit and then try again. It's not just like trying to push poop against a brick wall all the time. You know, it's going to give it a little bit and then try again. So whenever it tries again, you get more pain. And then peristalsis goes away. And then peristalsis comes back and you're once more pushing against a solid wall. And then you get a lot more pain. And so colicky or crampy abdominal pain, anytime you see that in questions, Tim, what that means is that there's an obstruction because the patient's bowel is contracting against an immovable object, and that's producing pain. But because of the slow wave that's always going through the gut, right? It only contracts in intervals. It's not perpetually contracting. So that's colicky, crampy pain. The rest of the symptoms should make sense. If you see it on an X-ray, you're going to see step ladder sign. That's classic small bowel obstruction. Looking at valvula condylentis, calaventis, which are those things, also called the plica circularis. Essentially stack a coin lesion, you might have heard it referred to as, but if you see those things, the gist of it is that it's in the small bowel. Air fluid levels, that's what it's also called, or the step ladder sign, because again, it's, well, that's not the step ladder sign, but. CT is the best exam. We're monitoring electrolytes. We want to use gastrographin because it's water soluble, and so if the patient has a perforation, it's amenable to that. Open surgery again, because you don't know the extent of what you're about to see most of the time from just a CT alone. Then ileus is what we wrap up this SDL with, and we talked about that again. It's like a flaccid atonic bowel, commonly post-operatively, due to basically sympathetic overactivation. Because anytime you cut somebody open, you know, whether they're aware of it or not, they are going to be fight or flight on the inside. They're going to be in sympathetic overdrive because they just got cut open and their body just had to deal with and currently has to cope with, when they're recuperating, a massive amount of stress. And so again, when your sympathetic nervous system is active, what's the bowel doing? Nothing at all, right? So that's postoperative ileus. And it can be iatrogenic due to drugs, especially opioids and antimuscarinics. And we're going to treat it with bethanechol, which is M3 muscarinic agonist, which is going to get that receptor pumping and restore some motility to that gut in lieu of the vagus nerve not working. So that's post-op ileus. We can typically diagnose it with radiographs. That's about all I got. Thanks for sticking around.